Good afternoon, and welcome to Interoperability Update, a webinar tweet chat combo from HealthSystemCIO.com, produced in collaboration with CHIME and sponsored by Hyland Healthcare. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or if you just want to simply view the tweet chat, you can look at it in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today, so if you have a question during the event, type it in, send it in to us, leave the default set to all panelists. We'll be looking at those and asking them later in the program. And you can download the deck by using the URL on your screen. It's at the bottom of most of our slides, and it's been sent out in the chat box. Just so you see how we're going to spend our time today, we're going to go about 45 to 50 minutes. First, we're going to have our panel discussion featuring Marc Probst, VP and CIO at Intermountain Healthcare, Dr. Shafiq Robb, SVP and CIO at Rush University Medical Center, and Phil Wasson, Healthcare Industry Manager and Consultant with Hyland Healthcare. So we are going to jump right in. And let's start with you, Marc. Can you give us an overview of your organization and role?
Sure, and thank you. I'm with Intermountain Healthcare. We have 25 hospitals. All of them except one are in Utah, so in that grand state in the Rocky Mountains. We are about an $8 billion organization. We have the largest health insurance company in the state, so we're really an integrated delivery network and have seen the value of interoperability for a long time in the things that we do. My role, I'm the CIO. The scope of my organization is about 1,300 people. We're a Cerner shop. We do a fair amount of self-development, and that's kind of the size and scope of the things that we do. Is that enough, Anthony?
I think that works well to get us started. Thank you, Marc. Shafiq?
Yeah, my name is Shafiq. I work for Rush. I am the CIO and the system CIO for Rush System of Health and Rush University. We are located in Chicago, Illinois. We are about $3 billion. And we have 3 hospitals and, of course, a university. We are an Epic shop, and interoperability is at the front and center for our clinical integrated network and our affiliations with our community, especially the churches, the schools, other teaching organizations, and the urgent cares and other pharmacies, all other aspects of healthcare that we support. So interoperability with the usability is key for us. Thank you for allowing me to speak today.
Well, thank you for joining us. Phil, you want to jump in?
Yeah, I'm a former 20-plus year CIO and CEO. I was a CHIME member. I've changed roles in 2015, joined Hyland Healthcare's consulting advisory teams, and we provide consulting support to our customers on how to maximize the use of our content services and medical imaging management solutions. Just a little brief thing about Hyland is that we provide a connected healthcare solutions framework that allows for all unstructured patient content to be captured, assessed, and managed through our core clinical and administrative systems. Our suite of enterprise content management is on-base, and we provide enterprise medical imaging solutions as well and try to address the clinical, financial, and operational needs of healthcare delivery organizations. The activities that we undertake in the area of making our systems and solutions interoperable is pretty extensive, with literally decades or more of commitment towards that effort. So thank you, Anthony, for inviting me.
You got it, Phil. All right, let's jump right into it. Marc, let's start with you on this one. I know you're very passionate. Actually, I'm sure all the folks on this panel are very passionate, but I know you specifically, we've been talking for years about this stuff, and we'll get into the government stuff and all that, but just give me an overview that, what you think the industry's accomplished over the last 2 years, some progress made type things.
Well, I think overall progress is being made. 3 or 4 years ago, interoperability was a topic of conversation, but not too much was being done. It was being done more by the informatics teams, the more academic approach to looking at what was happening with interoperability. But it certainly has advanced, and there are programs like HSPC and what people are doing with fire, and even what Phil was outlining, some of the tools that Hyland's put together that are advancing the overall conversation. But I would say, not to be a downer, but I don't believe interoperability, and I'll let Shafiq say what he was talking to us earlier about, but I don't think interoperability is tremendously well understood outside some of the buzzwords that CEOs might use, and then we get into a very deep conversation about interoperability. It seems to me it's something that business leaders really desire, but I'm not sure right now they desire it enough to really understand it and really focus the energy and the investment in it. But overall, it's certainly come a long way, baby.
Do you think, Marc, that, you talked about it advancing sort of from maybe narrow academic circles, and it's almost now, maybe with high tech and all the money spent, it's almost a political issue, right? I mean, politically, it's gotten to that level where you have politicians talking about this type of thing. Is that what you mean by it being elevated, at least, in terms of who's talking about it?
Yeah, partially. I am, and not to be too much of a skeptic, but, D.C. lobs on to big words that the rest of the industry is talking about. And, interoperability has been thrown out there as the potential solution for real problems in our country. And again, other than a very small handful of Senate and congressional staffers that really have dug into the challenges and the potential benefits of it, I just see it a bit as a buzzword that's being put out there, and not really truly what can be achieved with data if it's interoperable and available, in certain settings. And we can talk about the concept of sharing knowledge through interoperability, which is the real power. But I think the conversations has advanced. They wouldn't even talk about it 5 or 6 years ago before we really got through, in the midst of meaningful use. And now they're talking about it as a solution that, again, other than a small number, I don't think they fully understand what they're trying to do.
Shafiq, what are your thoughts on what's being said here?
I think Marc is right on the mark, but I'm an optimistic person. These are the United States of America. It took 3 presidents to get to where we are going. President Clinton talked about it. President Bush passed a law, and then President Obama funded it, and now the new government is here. Here are the good news. Seema Verma and Don Rucker, they're all supportive of it. The good news is that we are talking about fire. Fire's latest release will be allowed in February, which is R4, which will be an ANSI standard. So, and everybody's talking about open APIs. What that really means is that as we are understanding digitalization, and as we are understanding data, and as we are talking about actionable data, and as we are understanding that it is possible now to have usability of data, we are talking about cleaning up data and then share that wealth of knowledge that we have we have together, so that we can find cures, we can find solutions to the problem. Hence, machine learning and artificial intelligence have come into being. So as time has come from both aspects, the reason I have hope, because there is money to be made. And whenever there is money to be made, people join in and money to be saved. Old clunky HL7 days cost money, fire costs less money, and APIs will open up the door for machine learning and interoperability. That means there are new ways of funding it, understanding it. My biggest hope in interoperability and usability of data that is coming forward is that we have a window into humanity, and we have crossed the hype. We are now facing the reality, whether it is care equality, whether it is Commonwealth, people are now understanding at least at our level, Marc's level, that this is key for the salvation of humanity. Hence, you will see Amazon, Google, Apple, all big companies, even Microsoft, trying to get into it. The part that I have the greatest concern about is that interoperability is good, but we cannot forget the patient who actually owns the data and how we use the data. When the data gets out of all these big institutions, do we give one-time permission, two-time permission, five-time permission, and the GDPR? So I gave a long-winded answer, short, 2 sentences. There is hope, but we have to be very, very careful as we are talking about interoperability and usability, and we have to have ethics about the use of data.
So Shafiq, you're concerned about, as we get more and more interoperable, you're concerned about the privacy and the security elements or the implications of it if it's not done correctly?
That is true. As human beings, we, as scientists, we do things, but we don't understand how it's going to affect us. And I see, because we have 2 models of artificial intelligence running at Rush. So the biases of that, bottom line, we have to become better human beings as we are progressing in interoperability, usability, APIs, and artificial intelligence. I'm not raising a concern. I'm actually saying it's a problem if we don't become better human beings and keep away our biases out of this, because technology will mature, people will be interoperable, usability will happen because money is to be made. And whenever there is money is to be made, things happen.
All right, very good. Phil, you want to jump in here?
Sure. I would say that in our world, we continue to demonstrate interoperability capabilities at things like with the IHE, the Integrated Healthcare Enterprise. There's been some major developments there with the IHE conformity assessment, as well as at RSNA with their image share network, which is really helping to put some established standards on some of these profiles within interoperability that supports that for the customer base. So the customer base has something that they can count on. Interesting that Shafiq mentioned FHIR is that we've just deployed interoperability capability with Epic on a process called the Web Blob Pass-Through, which uses a FHIR call actually to pass information from Epic into OnBase for storage, and then that's reversed. That allows access to that stored OnBase data to exist with, to be available from Epic. And so we're using that FHIR standard today already to solve those kinds of problems.
Dr. Rob had mentioned that sort of HL7, is that the way he describes it is sort of HL7 is a thing of the past or being replaced or being replaced by FHIR? Is that the proper way to think about what's happening?
FHIR is an HL7 standard, and I think what he might be referring to is that the FHIR standards are just being finalized by the HL7 organization right now. Once those are finalized, there'll be a ton of IHE profiles that will emerge that will allow vendors to test with each other against those, which I think would be a good thing for the customer community.
Shafiq, you want to go into that a little bit?
Yeah. Just only 2 sentences. What happened is that the HTML5 and onwards, HL7, old traditional HL7 is clunky, and it does not have a way to, it is still used. It does not have a way to reciprocate on both sides and understand, hey, I'm FHIR, you are FHIR, just like a Bluetooth is. What FHIR does, first of all, it can be used on a browser basis. Second, it's easier. There are a couple, maybe 100 resources. And there are small pockets of people who are doing things, whether it's the Da Vinci people, whether it's us, whether it's you, or whether it's Hyland, trying to make it right. But the best news is that it will become an ANSI standard in February when release 4 comes. It will no more be DSTU2 or DSTU3, which is draft standard 2 and draft standard 3. So the difference between that and HL7 is clunky. JSON, which is the Java thing is also these are technical parts of making interoperability possible. Anybody who has an API can connect to another API, to another app, if they are FHIR compliant.
All right, very good. Thanks for explaining that. Marc, I want to ask you something. I've spoken to Dr. John Halamka a number of times about this type of thing, and he makes a distinction between interoperability that someone might describe as being what we're all working towards, or maybe someone who doesn't quite understand, a politician-type person saying every piece of data about any patient should be able to be exchanged with any other provider, every piece of data at any time. And he said that's probably not going to happen. That's probably not even a worthwhile goal. It's exchanging specific information in specific times with specific people. Do you see it the same way, that there's a distinction, that there's a finer definition that needs to be put on interoperability, a more achievable one or realistic one than everything about everyone at all times?
I suppose I see it somewhere in the middle. I mean,
okay.
Obviously, everything about every person at all times is, I would agree, that isn't even going to be useful. But there is an awful lot of information, and there's an awful lot of anecdotal information that we gather in our systems that actually modify what we understand about a person. These all become very important. So, simply sending some clinical result to someone else without some of that context, it could actually be dangerous and certainly not as useful as it could be. So I think there's somewhere in between that we need to get to. So it's not everything about everyone, but it needs to be enough data, and it needs to be in a standard format that we can actually bring it into our existing information systems and do something with it. Shafiq talked a lot about AI, and I would agree. I mean, there's an awful lot we're going to learn and we're going to do as we can get data into these systems and improve the care. But, a lot of the care just happens through our historical EMR systems. And if the data is not brought in and put into a user, if it comes in a PDF format, or it even comes in some kind of a window that we have to click into, the odds of that being used and of being of real value to our patients is diminished significantly. So I do think there is a level we need to get to, and I'm not sure the conversation's there today. But I do appreciate what Phil said, and there is a lot of progress being made. It's just taken forever to get there.
Right. Very good. All right, Phil, let's bring you in here. I want you to talk a little bit about the challenges that exist today. You want to give me some specific examples of things that, or activities that it would really, we almost should be able to do now, but are difficult?
Right now, I think there's been a lot of effort on the part of the vendor organizations to try to test against their current capabilities to bring those standards to fruition for their customer base. And it's been a complex endeavor. Much of the low-hanging fruit is that healthcare organizations, we think, need to understand how they can establish and manage interoperability within their organizations first. And then in that area of document and imaging experience, this has been accomplished with primarily the EMR implementations that are going on. However, many organizations don't yet today, I think, have a great handle on the imaging part of this, even within their organizations. And as imaging has become more prevalent at more enterprise locations, such as the bedside, if you think about it, imaging.
Hello?
Yeah, I'm here. Imaging is being used. Yeah. Imaging is being used for a lot of bedside functions as well. And so getting a handle on that level of interoperability is a challenge in many healthcare organizations today. So there needs to be work on that effort just internally within enterprises as those solutions come to the table for a lot of healthcare organizations. We see a lot of healthcare organizations that are trying to do things like bedside ultrasound, and they have no real place to send the data to. So they have difficulty in charging for that, and there's actually codes that allow you to be able to charge for those kinds of procedures, and we see a lot of organizations missing out on that.
Let's talk about it. Phil's coming from the imaging angle, and it often is kind of left out, at least it's not specifically addressed in some of these conversations. Dr. Rob, you want to talk a little bit about imaging and interoperability? Any specific thoughts on that part of interoperability?
Yeah, Anthony, if I take you to 2021, then it will help us all, or 2022. What are we trying to do? We are trying to get all information about me, Shafiq, so that people can guide me, take care of me, take care of my health, write a prescription, prescribe a behavioral pattern, as well as also make sure that I am involved in my taking care of my health and hence not utilizing the resources so that it's not burden on the country. That's the ultimate goal. So here's what's not happening and here's what we need to go to. First of all, you do not know, number one problem everybody talks about readmission. Most people go to some kind of a specialized care. You can call it a nursing home or some other name. Unfortunately, during this entire digitalization world and CCDA and everything else, we forgot the nursing homes and the SNFs and the specialized care. So the data exchange from there is very rudimentary. Think about it. Second, you're talking about mammogram and you're talking about MRIs. I call it all OGs, whether it is a dermatology, a picture, whether it's a cardiology picture, or the other pictures, and the interpretation of it, the early signs of deterioration of it, let alone bringing the data in, the intelligence behind that is also not shared today. Like if I had a small bilateral lymph adenoma or a Hyland lymph nodes, that is typically of sarcoidosis. So, early signs are there. It's not that it's not there. So here's the problem, that the complete data is not there. Even though we have data about me, I bought a house, I got married, I have a DMV record, I have my selling things that I bought, I ate, I spent my money, all those information are there. But that information about my behavior is not correlated to my health, is not correlated to my social determinants of health, is not correlated to what language I speak. So how will you guide my health if you don't know everything about it? And when the data becomes that big, it's very hard to interpret it. So you have to analyze it, understand it, actionable. That's what Marc was saying, which I totally agree with, somewhere in the middle. You can't have every information about me. But it would be nice if all those informations that aggregated came in and something happened to it. Twist it the other way. If I was a patient and I controlled all of it, and I gave it to any doctor, any place I want, in an analyzed format, then maybe I may participate more in my healthcare.
Marc, any comments on that?
Well, I love the vision that Shafiq just outlined, and it actually, to me, it gets much more complex because where we've historically been able to see our patients in our outpatient setting or in our hospitals or urgent care or home care or whatever, care is going to be provided in a much more fragmented way, and that's going to be in drugstores. It's going to be with your iPhone. It's going to be through telehealth, and you may go to your provider for your telehealth interaction, but you just may go to the cheapest alternative that exists in your community. And so data is going to be everywhere because we don't have good standards for that data. I think FHIR does, and some of the standards that are coming out on how to move it, but even what they're putting into those systems, it's just going to become a really big challenge. And so if you're going to go back to what John Halamka was saying, we really do need to define what those key data items are, how we're going to standardize them across all these settings of care, and then how I consume it at Intermountain so that I'm caring for the patients at Intermountain. I can do it in a way that's going to be rational and helpful to those patients. So it's a very complex environment. I still think we're early in interoperability, even though we've been talking about it for a while. But I am incredibly hopeful. All the people, like Shafiq said, there's money to be made. There's a lot of people focusing on the problem. However, just to end on a sour note, we still don't have a national patient ID, right? Which seems pretty basic to what we're trying to achieve here. Anyway.
Marc, you are right on the money, brother. When we were trying to do machine learning, the single most important thing was to clean the data, make the data in a standard format, or even if it's not in standard format, but to have a standard behind it. Oh my God, without that, you can't do machine learning. You can't do artificial intelligence. You can't enjoy the window into humanity without that.
All right, very good. Let's talk about some of the specific interoperability-related projects you've been involved in. Phil, you touched on a few things you're doing over at Hyland. Anything else you want to add, or maybe aspirational things that you're looking to do next?
Well, personally, I was involved with the development of an XDS document development project in Northern Illinois that was initiated to establish exchange capabilities between 3 different EMR vendors. And this was a query response for CCDs between the different organizations and what they were using. And what we found about that was the project was complex, difficult, but the real challenge was that at the time the EMR vendors we were attempting to work with were not ready for what we were asking them to do. We ended up defaulting to a secure email exchange option using the standard IHE, what's called the XDR profile, which is cross-enterprise document reliable interchange, which is essentially secure email on direct trust. And many providers at that time had to default to that level. It's pretty much in widespread use. But in terms of other interoperability projects, Hyland is heavily involved with IHE. We take the same software that our customers have on their systems to IHE, and that's the software we test with. You won't find us taking things like development or beta-based project software to that venue for testing. We test with the same software that is deployed within our healthcare organizations, and we still have a lot of faith just in working with that process to try to just create the interoperability exchange processes that are needed. Let alone some of the things that we were talked about in the previous segment in terms of just the data being rich enough and ready enough to be comparable for things like machine learning and such.
Very good. Marc, let's go to you. Can you talk about maybe the main interoperability project on your plate, the main thing you're trying to get done from an interoperability point of view at your health system?
Well, that's a little bit difficult of a question to answer. We are heavily involved in moving the fire standards forward, and like Dr. Stanhoff, who's been very involved in this historically, and so we continue to focus our energies on that and building, as many fire interfaces as we can within our own operations and within Cerner. We've worked really closely with Cerner, who's been very supportive of trying to move the interoperability conversation forward. So we've done a lot of development there as well. But I would say the biggest thing I'm doing is, and may get to it later as one of the questions, is advocacy and working with the federal government. I think they play a key role in us ultimately getting to the level of success we need with interoperability.
Very good. Dr. Rob, the main interoperability-related project on your plate?
So we are working on 2-3 different things. One is trying to get a fire. If there's an API from a physician, at least to get him the ADT feed to him. Secondly, when a doctor is seeing a patient, we are working with insurance companies so that we can develop capabilities so that we can do prior auth authorization. These are like pain points, little things, but our overall goal is to work with the federal government, especially with Don Rucker and Seema Verma and the HHS people, phenomenal people. They have a commitment towards making it right, and at the same time, with our vendor and other places like Apple and anybody who's interested, so that data transfer becomes just a tool. It becomes like electricity, what do you call that, utility, instead of being something more than that. So if you're asking what other secret projects I'm working on, like Marc said, it's very hard to tell you, but ultimate goal is to make this data pipeline go from one place to the other place with certain standards as a utility so that we can go to the next step. See, the next steps that I'm talking about, I may have talked very summarily, is from us to outside, us to the patient, and then the second step is from patient back to us and patient to outside, ultimately giving the control in the hand of the patient so they own their data, because everybody would like to use it. Gene editing is coming, CRISPR is coming, everybody's data will become the liquid gold. So once the utility is done, there's a money to be made, as I said before. Nowadays, when you give a consent, people use that consent for life. But that's not right. You may only want to give it 1 time, 5 times, 10 times, and every time you give that consent for the use of that data, it is a monetary thing. So we have not gotten there yet. So the project that we are working presently is to get the right data, the 22 first resources of FHIR, which are necessary for clinical understanding and interpretation, and making the lives of the physicians and nurses easier. Those are the ones we are working on.
Very good. Let me stick with you, Dr. Rob. The point behind this question is that you're both with large organizations. You have, big staffs, lots of things, cutting-edge projects and things like that. Is there low-hanging fruit in the interoperability area for, like, the community hospitals? Like, what should they be able to do, even with their resources? What would you suggest? Sort of, here are some simple things that you can do.
All right. So I have a very straightforward answer for that. For example, the new ways of transportation of data information, everybody uses 4G, 5G is coming out, right? So you will hear announcements, certain institutions will go with the 5G first. There is no harm in becoming second and third, but somebody has to follow it. That's one. Second is that open.api on the government website is there. If you go to FHIR.org, FHIR.org, there is step-by-step. It's not even like a difficult thing. Even if you have a staff of 1 or 2, people get interested. It's easy for people to follow and do that. Third, get into advocacy, get into the meetings that happens in DC, like ONC just asked, HHS asked opinion for people. There are public opinion that is being asked. People should get involved in it. It does not matter whether you're in rural Nebraska or rural Iowa or rural Illinois. You have a say in it. What Shafiq says is not the law. That means I'm only one among many. So my request to you is to say the institution may be big, but we are also focusing on it. And focusing is that in the olden days, we didn't have that much resources available. Now we do. FHIR.org, Open.api, Google, ONC, HHS, and Open APIs, and it's all available. But if you don't have resources for anything, then at least you should have some opinion and actually help the government form the opinion at the CMS level, at the HHS level, and at the ONC level.
Very good. Phil, I'm wondering if you have any thoughts on that, the low-hanging fruit question.
Well, I'm not sure there's a lot of low-hanging fruit in interoperability. It's a complex endeavor. It can't be undertaken with anything less than a full commitment. What we try to do is try to improve the interoperability that exists between our products and the EMR vendors, some of which have their own methods and are dependent upon the exchange of documents between them. On the medical imaging side, we see a lot of silos of medical imaging components within organizations. As organizations have acquired other organizations, we've seen some organizations that will have upwards of 15, 20 different traditional PACS systems. And so what we try to do is help those organizations establish an enterprise-wide imaging strategy that helps them consolidate as many of those as possible to prepare the imaging infrastructure for the kind of interoperability that will be coming in that space as well. And so, from that perspective, those are the kinds of things that we're undertaking today, and those are the kind of things that we think healthcare delivery organizations can do to help to prepare their organization. Just working on that ability to interoperate within their own organization is something that we see a lot of organizations wanting to take on right now, especially in the medical imaging space.
Very good. Marc, let me go to you on this one. What can or should government be doing to improve the interoperability situation, and how much of the problem can government fix, and how much has to be evolution in the private sector driven by market forces and the money to be made, as Shafiq put it?
Wow, I hope I can be totally Pollyannish in this answer, but, I really agree with what Phil just outlined, and I appreciate so much the work that organizations like Hyland are doing in that space, but it makes me sad that it is that complex, that we've made such a difficult environment for sharing data between organizations. And so I've been a huge advocate that the government has a role to play. If we're actually going to get to standards, I haven't seen it for 25 years, 30 years, to where we've been able to get to standards in a, private, industry-led kind of efforts. We've made advancements, but we can never make the really difficult decisions to solve some of the problems that the country's having. It was probably 3 or 4 years ago. We did some math on it. It's literally hundreds of thousands of lives and billions of dollars that are being lost every year in our country because we can't adequately share data and knowledge about that data between organizations and healthcare. And it's happening too slowly. So I believe the government has a role to play. Can they do it on their own? Heck no. But the government could start to define what we're trying to do with interoperability, and then they could take some leadership or fund leadership by some private organization or government private organization and create the leadership to get to real interoperability. And to me, that's what we've lacked, is that national leadership on what we're trying to do and how we're going to go about doing it. So we have a lot of organizations that are solving very real problems that are helping us today. And like I said, I so appreciate the vendors and the technology companies doing it. But in my mind, it's going to take the government to play a very key role and get serious about it. But I don't hold out a tremendous amount of hope.
All right. Dr. Rob, let's go with you on this one. You made some allusions to care quality and Commonwealth, and we know that CLASS did a report recently about what those groups were doing and some of the progress that was being made. So, Dr. Rob, just take us through what your observations of what's being done out there.
So, as you know, I'm a very optimistic person. I believe in hope. I believe in people. I believe in humanity. So, having said that, the good news that came out recently that care quality and Commonwealth will work with each other. That's the first thing. That means they will, if those two work with each other, then 2 or 3 or 4 or 5 major vendors that are in the EHR world, they become automatically what you call interoperable. If by that I mean it's a broad term, that only takes care of the EHR part. The imaging part and other things, I love what my brother Marc said. The government has a role in it. What everybody is missing in this interoperability discussion, and what I'm trying to, and which Phil also mentioned, is that there are different types of data. There is a documentation data, which is the EHR data. Then there are devices data that come from different devices. That means breathing, vent information. Then there are imaging data. So once we understand that the interoperability does not mean only EHR vendors talk to each other. So that understanding of all those data to come, and then somebody or some group of authority or some people who are smarter than me sit in a room and say, hey, these are the minimum and these are the maximum information other than the CCDA that needs to go from one place to the other place to help humanity. That's the first step. So I think that by the care quality and the Commonwealth people saying, that happened about, I think, 2-3 weeks ago, or I don't remember the exact date, when they made a press conference and CLASS did a paper on it. I was with Adam Gale, who informed me about this. So this is one step. Second is that the Da Vinci project, which includes all the payers, CMS, and one or two providers, they are also tackling this to come up with a standard, and give it to HL7 to publish for all, so that it's free of cost. It's not like somebody's got to pay for it. Similarly, in the world of radiology, as DeepMind and other people are showing that there is a way of getting things done. Similarly, with the oncology, ASCO, they are proving that data is going to happen. So in the world where there are small, bright hopes, somebody or some governing party should sit down, like Marc said and Phil said together, hey, man, let's give you 11, 12 things. But the biggest part that we have forgotten are the people in nursing homes and other facilities where people go from the hospital, go there, and then they come back, or go home and come back. So this is costing a lot of money within the healthcare system today. So I have hope, but things are happening, but they are happening in small, sporadic way. They're not happening in a fully coordinated way.
Very good. Thank you. Marc, let's go with you on this one. Types of advocacy out there. You won the Public Policy Award from CHIME, so you're obviously very passionate and involved. I'm sure you would like your CIO colleagues, even those in and out of CHIME, to all help move the industry forward. How can they do that?
Yeah, I mean, you talk about advocacy, and I can in a second. I think the first thing we all need to be doing is really educating our leaders. They're the ones that spend the money, right? CFOs, CEOs, boards, and they make the big decisions, and they need to understand interoperability beyond it being a buzzword. You know, what are the real benefits that can come out of it? You know, set the aspiration high within our own organizations, so that they too are making this conversation happen in the right forums, whether those be industry conferences or whether those be going back and actually meeting with our public leadership, our federal leadership. So I think that's a key start. And then secondly, advocate, support people like CHIME. I mean, for the small group that CHIME has within Washington, D.C., they carry an incredibly large stick. And the more support they get from us as HIT professionals, the better and the better they can do their job in supporting us and trying to get solutions in place. So, you know, I wouldn't be quiet. I think we need to set our aspirations high. Then we need to educate and advocate, and those would be the things that I would suggest.
Excellent. All right, ask a co-panelist. Phil, what do you got? You got something for one of your colleagues here?
Well, I'm just curious. You know, I've talked a little bit about how organizations are trying to prepare their EHR solutions. I mean, one of the things that we've kind of heard quite a bit about is that right now, if you look at what Gartner says, only about 25% or so of healthcare information about a patient is available in today's EMR application. There's other data that exists within the healthcare enterprise that sits outside of that isn't really within the necessary workflow that a provider might need to have access to make appropriate decisions. And so I'm just interested in how have our other two panelists, how have you completed the necessary discovery analysis within your organization to understand how can you capture and manage all of the content and imaging content that exists within your organization and bring those into a more functional EHR to contain more data that's there.
Shafiq, you want to take a stab at that?
So it's not only imaging, Phil. For us, the most important thing is when a doctor is sitting in an office, he or she has to decide whether he or she has all the information about the patient or not. So our number one focus, by the way, we also own an HIE by virtue of being members of Rush Health. So what we have done, this is the part that nobody says. You have asked a question. So people like us and people like who are trying to do the interoperability, we are fighting for fire. Okay, we got that. We are fighting for interoperability. We got that. But the tool sets to get all the data in different ways and making sense of it. So we have gone about different ways. There is no one tool set. So what we did, we created our own HIE so that we can get different data from different people and make the data right, scan it and clean it and put in a format. On top of it, what we have done is that at the time of somebody getting a scheduling, at that very moment, if it has prior, what do you call, images, we start a web crawler, like we start a search for it within our system, within the neighboring system, within the local radiologist system. With the consent of the patient, we try to bring it in even before the patient comes to see them. We also ask the patient if they have anything that they can upload or share, either from a computer or from an iPad or from the radiologist, so that we can bring it in. So we are trying to bring information from different sources at different time at the point of scheduling. But not only images, not only dermatology slides or cardiology slides, hemodynamic slides, but also EHR information. Not only that, we're also bringing longitudinal study of glucose or device that they were on, so that all information is accumulated in one place, synthesized, analyzed, made sense, and then through Care Everywhere, as we have in Epic, we bring into a tab for the viewing of the physician. Think about it, like somebody said, it's complex. Well, it is complex, but that's how where we are. And sometimes we fail. Sometimes we fail that we have not been able to accumulate it. So what we are now doing is that we're taking all the information from SNPs and other places, putting into one place, synthesizing, analyzing it, talking to the physicians and the nurses, how they are utilizing it. Most key here is in our workshop, we are making the data usable so that it can be used in a quick way, in an actionable way.
All right, very good. For the sake of time, I am going to move on to our audience Q&A. I want to get a couple of questions out there to the panel. First one, how are your organizations expanding the reach of information exchange to sources where social, educational, or environmental determinants of health can contribute to the plan of care for a patient? Marc, thoughts on that?
Well, the question was how, so not very well. But we're working at it. It is a huge challenge. If you go through the answer Shafiq just gave you on all the things that Rush is doing to try and get that information, whether it be from SNPs or whether it be from social media and the social determinants of health, there aren't really good places to put it. So you end up developing your own data stores and strategies for managing that data, and we're doing so. But it's a moving target. We end up investing an awful lot in people and time to build out this so that we can get insights from that data. But I would say, we're adolescents at best at doing this, but see the importance of it.
Very good. Next question. In addition to extended care facilities, we also struggle to connect with specialized behavioral health care providers. What ideas do you have to help address this gap in awareness and knowledge? Shafiq?
So, like Marc said, we are trying to be better at it. So I'll give two examples. One, we work for by using different video techniques or to capture data, and by using mobile iPhones, questionnaires to help people so that we can get the data to them and back to us. We developed a methodology of doing it, and the thing what we did is that there are four different healthcare systems, which is not ours. We shared it with them so that we have a common standard of getting those information back to us and also help the loved ones. We're doing a full project with the veterans who come back after their service. So we have some limited success in it. Same thing, we have some limited success with social determinants of health. Yeah, we don't have it all. We copied from CMS, but we have partnered with third-party vendors who have more specialized things in it. We try to bring it into our EHR and to our social worker and back to them. And we also don't have resources, that means the referred directory from the community. So we partner again with a third-party company that has those directory like the transportation, food, lodging, and clinics. So we are taking care of this with a handicap.
Very good. Phil, you heard the two questions just asked. One had to do with social, educational, environmental determinants of health. The other one, integrating behavioral health care. So people are thinking about and concerned about integrating from that hospital system to those other venues where the patient goes. We know home is one. We know that they want to know what's going on in the community with a full picture of the patient, and then they need to be integrated with the other care venues that people can go to, such as rehab, nursing care, long-term care. So you've got these patients going back and forth from the hospital to home and different venues. You have a desire to bring in more information about the patient. Just your thoughts on, obviously these questions are what's on people's minds, so your thoughts on that.
Well, in the area of the information exchange to sources for social and educational or environmental detriments, we are not necessarily providing, the automated intelligence tools, but we do provide extracts to many of our customers. Some of our more advanced customers, include Yale, UNC, some others that are actually taking extracts of DICOM data and sending that on to their researchers that are doing machine learning, and they're integrating that data with other sources of where they're pulling data into. So we are supporting that right now. We do the de-identification of the data so that data can be used appropriately. In the area of extended care facilities and other components, we do have a big effort going on the on-base side where we provide an extended care capable solution for long-term care that can integrate with an acute care solution that exists within a health system, so that those records can be exchanged relatively easily when those two solutions exist today.
Very good. Well, we're just about out of time. I just want to read one comment from our good friend Chuck Christian, who said, I agree with Marc. Educate your leadership. However, the CIOs and IT leadership need to engage and get better informed. Don't just allow the EHR vendors to be their interoperability voice. So always appreciate getting some wisdom from our good friend Chuck Christian. That's about it. We're about out of time. What a great discussion from our very enlightened panelists, hardworking, passionate panelists trying to improve care not only in their organizations but in the industry. So we appreciate them participating today. Hope everyone's gotten some good information and takeaways out of it. When you close out your WebEx window, you're going to go to a post-event survey. If you could answer that, we'd appreciate it. For those of you with continuing education interest in today's event, if you have the CHIME CHCIO certification, attending our webinars gets you one CEU. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. We'll have this posted to YouTube shortly. You'll get an email when it's ready. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule of webinars. So with that, I want to thank our panel, Marc Probst, Dr. Shafiq Robb, and Phil Wasson. I want to thank our sponsor, Hyland Healthcare, for making the event possible, and I want to thank you for attending our event. So with that, everybody have a wonderful day. Thank you very much, guys.